Pennsylvania. He is the James and Agnes Kim Associate Professor of Neurosurgery with a secondary appointment in radiology. Dr. Burkhardt was trained at the University of Leipzig in Zurich, UCSF, and NYU Langhorne, where he learned and now specializes in microsurgical and endovascular treatment of complex cerebrovascular diseases, including aneurysms, arteriovenous malformations, cavernous malformations, intracranial bypasses. Dr. Burkhardt is nationally and internationally recognized member of multiple neurosurgical and neurointerventional societies, including the AANS, CNS, ESMIT, and SNIS. He has authored numerous peer publications on various topics in the cerebrovascular and neurointerventional world. Today, we are very excited to hear his talk on the treatment of aneurysm using the various intrasaccular devices that are now available. Please help us welcome Dr. Burkhardt today.
Thank you so much for the kind introduction, Clint. I'm sharing my screen here. Right, can you see my slides?
Yes.
Great, thank you. So thank you again for having me, and it's my pleasure to talk today about intrasaccular devices for the treatment of intracranial aneurysms. I know it's a specific honor to speak the Seattle audience because I know for a long time they're cutting edge, especially in the intrasaccular device space. A lot of experience with web, also with Contour. So I'm happy to share my thoughts today. These are my disclosures. I'm site PI for most of the available IDE trials for intrasaccular devices, and I'm a proctor for web. So that obviously affects the talk, but I'm speaking, just giving an overview over the different devices. So again, quick intro for different devices available, and then jumping right into some case examples, and I'm trying to show you where I think some of the devices have advantages over others potentially, or in which cases they're pretty similar. So if we start, like, why are we doing intrasaccular aneurysm treatment? I think the challenge nowadays is still the aneurysms, the wide-necked aneurysms in bifurcations. The challenge is to really treat the aneurysms, especially minimal invasive endovascularly, to avoid a recurrent aneurysm. And we have obviously a lot of different options available, most of the time endovascular with some sort of assistant device in the parent vessel, be it like one stent or Y stent or any other devices to increase the coiling density and avoid like recurrent aneurysm formation. Also, obviously, microsurgical clipping is a very effective way to treat these wide-necked aneurysms, but would require open surgery. And as we thrive to more minimal invasive in the future, the idea came up to, do we have an option for these aneurysms to really seal off just the aneurysm with a better option than leaving something in the parent vessel behind or doing open surgery? And that's where the concept came up. Maybe there's a way to basically plug the device with like one and done to simplify the treatment, and filling the aneurysm, a so-called intrasaccular device. And this is the most commonly used device. We have the longest data on it's the web from Terumo Neuro. You can see it looks kind of like a basket, and with a braided technology, so similar to a flow diverting stent, similar material, but inside the aneurysm. That's not necessarily a very new concept when you look into other spaces, like especially cardiovascular or peripheral. There are devices that look pretty similar for different indications, obviously, most of the time for septal defect closure or vessel takedown, but they kind of look similar, but similar concept. You basically plug the aneurysm. And the concept is for these intrasaccular devices to have a metal coverage around the neck. You can see what happens over time. And it really depends on the size of the aneurysm, obviously, of the neck, depends on the device you use, because the braids vary really from size and device. So you get some sort of metal coverage, but you also fill the aneurysm with the device. So it's kind of a combination of like coiling with flow diversion. Obviously, it's not a dense coiling, but you have a combination of metal coverage, but also filling the aneurysm. This is a very busy slide from Terumo Neuro, just explaining a little bit more the concept of the web device, the microbait technology. You can see here really the number of wires depends really on the device size. So it's a little bit complicated, but all of these intrasaccular devices have a nitinol wire with most of the time platinum wire core. And you can see how small they are in comparison to a human hair, so 13. And yeah, so these are the details how these intrasaccular devices are kind of made. So so what is available currently? So we know the web, the Terumo Neuro is probably the most common and most known device if we talk about intrasaccular. So there are two shapes, an SL and SLS. The most common one I would say we use is the SL. The SLS is very rare. I'll show you some examples. Then there's a device called Contour from Stryker. You can see it's a little bit of a different design. So it's open at the top, and it's really made for plugging the neck of the aneurysm, as you can see here. Looks like a cone. Then there's a device from the company Galaxy. They had actually two devices, Seal Arc and Seal Base. So you can see the Seal Arc has an arc going into the aneurysm dome, plus a base to get really good wall apposition in the neck area. And then for more shallower area aneurysms, there's also a version which is basically like just a seal portion. And then there's one more device, the Artisse device from Medtronic. It looks similar to the web, but it's a dual layer device, and it's a little bit softer. And the idea is to confine more with the aneurysm. So are these all available to us? No, unfortunately not. So if you look which of the devices are FDA approved and have the CE mark, so you can see the web is the longest data available and availability in Europe and the US, FDA approval in 2018, and the 17 system since 2021, and CE mark since 2010. Contour and Artisse are available in Europe, but in the US only via IDE studies. So Contour, the IDE study finished with the last patient enrollment last year in December. We're still waiting on the data, so we don't know the results yet. Seal It just started, as well as Artisse started. But Galaxy had a very fast enrollment, so they're almost done, I think down to 3 more cases for the enrollment, and Artisse Medtronic just started. So we will see what time will bring and which devices we'll get in the US with FDA approval in the future. If you think more about basics in intrasaccular, so there are really differences compared to coiling or flow diversion, obviously. So here, the goal is really to get lateral compression. That's the most important thing. And we all learned that the hard way. So in the beginning, when we were trying to just like size our devices based on the aneurysm, we realized that we have seen more recurrent aneurysms and complications, because we really want to oversize the device to make sure we have very good lateral compression to seal off the aneurysm. And we don't really focus on the top of the dome, especially if there are additional blebs. Like in this example, we really want to focus at the bottom, at the neck, and the lateral compression. Also, aneurysm neck matters. This is a nice illustration showing that obviously smaller neck aneurysms have a higher chance of occlusion with intrasaccular devices. Here we have an example of a Contour publication where you can see that really the mesh density is much higher at the center of these devices. So obviously, the lower the inflow is into these aneurysms, the higher you can get a mesh density and occlusion rate. And the wider the aneurysms, there's a little bit of a wider range. And also, if you look at positioning of the devices, each device has different recommendations where the device should sit. an example, especially for the contour, is the contour sits lower compared to other devices. If you look at the data, most of the data long-term available is from web. It's also because it's the longest device available. And so there are really a lot of studies. And there's also a web occlusion scale I need to mention here in this regard, because it's a little bit different with intrasaccular devices in terms of what do we define as a good outcome in these patients. And if you look at our coiling data, the Raymond-Roy occlusion classification, where we have class 1, 2, and 3. In intrasaccular, we found out that if you have a neck remnant, it's actually very stable. And that's, for us, an adequate occlusion and doesn't necessarily require retreatment. So a lot of these studies also include neck remnant into an adequate occlusion scale. So complete occlusion in addition to neck remnant equals adequate occlusion for intrasaccular device assessment. And then obviously there's aneurysm remnant, and that's similar to class 3 of the Raymond-Roy classification. Sorry, these are very busy slides, but I just want to show you some data long-term, especially. So the CLEVER study is the 17 delivery device, and you can see so occlusion rates are getting better over time. That's also, I think, with advancement in the systems, but also in the experience of the treating physicians with or correctly sizing the devices. So it's about 60% complete occlusion rate here in the CLEVER study, with 20% neck residual. So if you group them together, it's about 80% and aneurysm remnant. And that's durable in the EU studies over 5 years. So over 80% occlusion rate here, adequate occlusion, and the same in the US, as you can see here. It's also to highlight that really these devices are safe for a one and done for these more complex aneurysms, in terms of endovascular treatment. And you can see a pretty low retreatment rate with 0 mortality, morbidity, or rebleeding after treatment with high occlusion rates. So if we dive into the different devices a little bit more detail, so if you start with web, since we have most data on this, this is the design of the SL, and you can see here the different sizes of the web. And this is the sizing graph where you can look at your aneurysm width and your height, and based on that, you can come to a conclusion which device would be ideal for your aneurysm. Show you the next slides a little bit how to do that. The spheric, single layer spheric size, the SLS, is really a device I just used a couple of times, I would say, because most of the time we really want to have good lateral compression, and the spheric design is not really made for the most common aneurysms we see. So in some scenarios, if it's really the ideal round-shaped aneurysm, but as we know, most of the time they're irregular, and you want to get really good lateral compression in these wide-neck aneurysms. So this is how you size it. So I usually look on AP lateral, so at least two different views, projections at the width of the aneurysm, and then also the height, and then you average that, and then you can use here this scheme for the device selection. So look at the width here in this situation, 6.2. You go up and see what the size is, and then you can find your ideal device. So for me, I mean, I usually try, you see this at the bottom, usually try to oversize by about 25%. So that's usually 1 to 2 sizes up in width. So if you have a 6 average, you go either with a 7 or with an 8 device, depending on the height. So I'm usually more aggressive that the larger also the device goes. So if it's a 6, sometimes even would go to an 8. And then you have to obviously decrease the height by 1 or 2, depending how high you go. The deployment is pretty straightforward. I would say there may be 2 deployment techniques. So one deployment would be you start very high up in the aneurysm dome and basically unsheath the device. Another alternative is that you're maybe in the 1/3 of the aneurysm and you push out the device a little bit, like highlighted here. And once it looks like a Hershey kiss, you can say that here in Pennsylvania, it becomes very soft, and then then you can actually move the device all the way to the dome. Because you have to be careful. Initially, it's very pointy, and you can potentially perforate the aneurysm dome if you don't wait until it's really flared to the Hershey kiss situation, and then you continue the unsheathing, the deployment of the device. Here's a quick example for an ACOM aneurysm. Here you can see the height, the size. The width was 2.5, 2.6 on average. Height around 4. So here the smallest device is a 4x2. So we used a 4x2 device. This was done through a femoral access. And here you can see the position of the VIA-17 microcatheter. So pretty straight going into the aneurysm. And you can see the first fluoro, how the device comes up. So the 17 system is a stable system, even if you don't have an intermediate pretty high up. And here you can see we're basically on the neck already here with our microcatheter. So I'm able to push it out a little bit. And then in the next step, once it flares, you can just push the device out here in this case. And then before detachment, obviously do final runs. If you're unsure, you can always do also a 14-second dyno CT just to make sure you have it well opposed where you want it. And then the detachment, here my microcatheter is a little bit too close for the detachment. Usually I run it further back, but in this video you can see it. And especially in the ACOM, you see how it like settles back. So the roadmap is a little bit off. So it's useful to do a new roadmap once you're in there with the microcatheter. And then these are the final runs with good stasis. And then a 6-month follow-up shows complete occlusion of the aneurysm. So it's a pretty straightforward example. And you can see when you size it right, and the device has really adequate wall position. The problem is if you don't size it right, and I want to show you also some examples just to make sure that you don't do the same mistakes I did in the beginning. So you really want to size it correctly. If you undersize it, it's really possible that the aneurysm is still filling on follow-up. It's just floating, basically. It's possible it pushes up. It's also possible that it turns. So a couple examples. So here, in this case, you can see the width is around 4 millimeter, and here in the beginning I was more conservative, so using a 4.5x2. Here definitely is undersized, and everything went well here. Device is in here, but you can see it's kind of pushed together. It's definitely not the right size in terms of width, but also not height. And on 6-month follow-up, it looks basically the same. So here in this case, we decided to clip the aneurysm. You can see the device here intraoperatively. And the good news is the devices are very soft, so you can clip across it. And here you see the intratope angiogram, complete occlusion now of the aneurysm with the aneurysm clip. Here I was just curious. Usually I don't open it because it can also cause inflammation, but I actually wanted to see because it looked really that it's just floating. But although it looks like floating, the device is actually really integrated in the wall. So it's not, it's good to know. So it's not unstable. So I'm 100% sure this device wouldn't like float out, after a couple of months. It's integrated in the wall, but it just didn't do the effect of occluding the aneurysm. So here, once I opened it and I saw the mesh exposed, I really made sure to get rid of everything, just that it doesn't cause any inflammation on the optic nerve there. Another example also for undersizing, here in this case, the aneurysm was also just the size of the device was just sized by the size of the aneurysm, basically. And you can see initially it looked great, the occlusion right before the detachment. So this is before the detachment. Here's a little graph I made on PowerPoint. Sorry, I'm not like a great artist, but I think you get the concept. So here, after the detachment, what happened was that the device basically shifted. And you can see that the device is now really in the bifurcation, so not even really in the aneurysm. So in this case, obviously, you want to get it back in, and the best to do that is with like a stent. So here, placed an Atlas stent, and that actually pushed the device into the aneurysm, the final run. So at this point, I stopped. I wanted to give it time just to see what happens. No complication, patient did well, but on 6-month follow-up, as expected, the aneurysm is still filling. You can see how the device is upside down, floating in the aneurysm. So here we decided stent was already in place, so we added here some coils and, to occlude the aneurysm that way. And this was the final result. And that was stable on follow-up. It continued to be occluded. So these are two cases I wanted to show you to make sure, size it correctly, and try always, in my perspective, try first a bigger size, even if you switch it, if you feel like the size was too big, but it's better than undersizing, because these devices are very soft. So I rather try to oversize the device a bit more than under. Here, some different deployments. So you can also use intrasaccular devices when it's kind of an angulation, as you can see looking up. For web, there are on the VR17, there's a 45 and 90 degree catheter, and that can be helpful, especially in these cases where really the trajectory of the deployment is more in an angulation here. So this is the deployment here, an example for that. So here also starting pretty deep in the aneurysm and mainly unsheathing, and then readjusting once the device is softer. You can push it up a little bit more. Here again, this angle, and then these final runs before detachment. And final run. So so with these new pre-shaped catheters, I think that's a big advantage to deploy it in the way you want to. You can also do it with a straight catheter, but in some scenarios that's helpful. This is an interesting case. So sometimes really the trajectory of the neck is pointing really in an awkward way where it's really challenging for you to deploy. So here, if you look at the 3Ds, this is a proximal A1 aneurysm, and the dome is actually pointing to the right. It's a right carotid aneurysm. You can see how the angulation is really hard to get in here from that location if you come from the right side. So, but if you look at the A1, actually the shot from the ACOM looks actually pretty favorable. So here, during the angiogram, we actually did a compression. You can see that on the right side here of the left neck, and did an injection from the right side to see if there's a good ACOM. And you can see that it's cross-filling really nicely. So here the idea was really coming from the left side, going through the ACOM, and then deploy the web basically as a straight shot in the A1 here on this side. So this was the setup. For the right side, we just did radial for images, and then the treatment system came from femoral. Here just some videos how we cross through the ACOM. Capacity here, and then the via is going over to the contralateral side, so transcirculation. And then now we have a different angle, so now we look more at the lateral. You can see even though we come here now to the A1, it's actually still curves a little bit down into the dome. So you can see how the via is now tracked into the aneurysm over the wire. And then the deployment of the web. So we used the 4x2 here. I was more conservative, so you saw I pushed it out a little bit more over the neck, and when it was softer, now I'm pushing it, trying to push it into the aneurysm. But in the first attempt, I had the feeling that I was really more in the parent vessel than I wanted to. So then in the next step, I readjusted. So resheathing the device a little bit, keeping it still soft, and now pushing everything a little bit forward and unsheath and deploying the device again. Now we're definitely deeper in the aneurysm, but it's also compressed, as you can see here on the picture on the right. So now in the next step, now I'm pulling back slightly to release, to make sure the device is really deployed widely. But much better than the first deployment, so because now I'm really at the neck here. And this is how we left it, detached the device, and these were the final runs. Also here on the dyno CT, you can see on the right side, that it really covers nicely the ICA terminus without protruding into the parent vessel. And we just recently did a 1-year follow-up on this one, so it looked really good. So these are obviously rare scenarios, but can be done if if the angle is more favorable for a transcirculation approach. Another areas where these devices can shine, if you don't treat them with open surgery, if there are perforators coming out of the neck, so you can place them pretty precisely. So here in this case, deploying the device really deep and making sure to keep it in a position where it doesn't cover the branches is possible. Like here, when you're able to get lateral compression in the dome so that the device can't come back. And here, this looked really nice. The branches were open and continue to look like this on follow-ups. Also ruptured aneurysms. Here in this MCA aneurysm, it's effective. You can see the initial deployment pictures and then a 6-month follow-up with complete occlusion. Also previously treated aneurysms, so this was previously ruptured aneurysm with clipping and a recurrent aneurysm, pretty small, but a good space to get a 4x2 web in here, and that looked great at 1-year follow-up, so complete occlusion here in this case too. If we switch gears to other devices, so we heard a lot about web. So what is the difference to Contour, and why was that brought up as a new device? So the Contour looks completely different. As you can see here, it's a neck bridging device, and it's dual layer. So the web is a single layer, circular braided, and the idea is to do flow diversion, flow disruption at the neck. You can see here more the details on the right side. So CE mark was in 2020, and Stryker acquired Ceres during the IDE trial in 2023 here in the US. That picture I showed you at the introduction slide, but if you look here at the benchtop model, so the idea is really to disrupt the flow at the neck level, and you can see also how low the device sits compared to the web. So here, that's definitely something to learn, and also during the trial, to be more comfortable to have it really sit lower than the web. The idea for Contour is to be a little bit more simple in terms of sizing. So you can look here at the size charts. There are only 5 devices in the US IDE trial. And here are the maximum aneurysm width, neck size to decide which device you use. So going back here, treated aneurysm width between 2 to 10 millimeters, 10.5 millimeters. Here again, so 21 microcatheter system for the delivery of the 5, 7, and 9 sizes, and 11 and 14 go through a 27 catheter. There's not a lot of data yet, obviously, from the US. We're waiting on the data from the IDE study. There is a good publication from 10 European centers who showed mainly in patients with unruptured aneurysms, very favorable results with 91.5% adequate occlusion aneurysm occlusion rate and favorable safety profile. And here are some more details on safety, technical success. The neck trial, which completed in December 2024, it included aneurysms in bifurcation. So here, compared to the web studies who didn't include PCOM aneurysms, so this was a study where you were able to enroll PCOM aneurysms, and the rest pretty standard, 20 sites, 250 subjects. And here, the primary effectiveness outcome was Raymond Roy 1 at 12 months DSA. So here a few examples in terms of sizing. So this is an aneurysm you can see here with the width between 5.5 and 6, and you can see that it falls into like a 9 Contour size. Here's some more details, because I'm not sure if everybody, if you were listening, saw a Contour. This is how the device looks under the floor. So microcatheter tip, then you see the device with a marker and the stainless steel delivery wire, and that's how the deployment is. So you you start pushing out the device, and then you keep unsheathing and getting the device right over the neck to sit right in the neck, and then ride your microcatheter back up. And then you do the stability test to make sure it's really in position. And then here's the detachment zone. And then you can detach the device, and the final runs with the stasis, as you can see here. And in this case, here's the 1 year follow-up with complete occlusion. Another example of a small aneurysm right between the PCA and SCA here on the left side, small aneurysm. You can see here the width 2.8 by 3.9 and the height around 3. So this is sized for like a small device. You can see the setup. And you can see also how low the device sits, but that's what you want to really seal off the neck and get good compression around the neck. And these are the initial pictures of good stasis right after the deployment. And this was the 1 year follow-up with complete occlusion and patent SCA, as you can see here. Also for very shallow aneurysms, I think here's an example of a fetal PCA aneurysm, not very deep, like 3 millimeters, and really an adventure. At that time, the sizes 6x2 and 7x2 from web were not available, so that was a huge advantage too. And here you can see how the Contour 7 gets deployed in that aneurysm, so it's riding up. And here I obviously started deep in the aneurysm because it was not really deep, 3 millimeters. So starting deep, once it's deployed, and you start pulling back and do your stability test. But I really wanted to make sure we don't have a dog ear, so you can see how I'm pulling to get really the device as favorable as possible, as low as possible here. And these were the initial runs before and after the detachment. You can see nice stasis and preservation, obviously, of the PCOM. And yeah, these were the final pictures. Also looking here at the 14-second diner, really nice position here across the neck. And that was the 1 year follow-up. You can see it continues to be occluded and seals off nicely here right at the fetal PCA origin. Also, aneurysms were allowed in IDE were previously treated. So that's also a unique fact for this study. So previously coiled aneurysms, here you can see challenging aneurysm with actually like a bleb across the neck. So recurred, it was a ruptured aneurysm, so needed retreatment. And here in this case, that was a great example how the Contour basically seals off that aneurysm and that bleb in the neck with nice stasis. All right, a few words to Galaxy. What are the differences here? So there's this ongoing trial, IDE trial. There are 2 devices I mentioned before, the base and the arc. So 2 different configurations. And the difference here really is that goes up to 90 millimeter aneurysm. So these devices are really made for large aneurysms as well. And in the trial, not only wide-necked bifurcation aneurysms, but also there's a subgroup looking specifically into sidewall and ruptured cases. So it will be interesting what these studies will show. This is the enrollment currently. So you can see three patients are missing in the ruptured group. The wide-necked bifurcation aneurysms and the sidewall aneurysms enrollment is already completed. So we'll hopefully soon, like in a year, we'll have also some more insight about the follow-ups here. This is the sizing chart. And basically, if your aneurysm has a large dome, then obviously a more favorable use of the arc device. If it's more shallow and wide-necked, the base device shines. And here you can really see the XL sizes, which are pretty unique for this. And different catheter sizes from 0175 up to 033, depending on the device. Here are some slides who were presented by Dr. Artisse and Dr. Jankovic at SWIN and Brain Conference in London and Orlando. Here you can see the neck coverage of the seal arc 6 has a higher neck coverage than the web, and also more flow diversion properties based on this in vitro particle imaging velometry. And there were some data presented on follow-ups, but there's no one-year data follow-up presented. And these are pretty mixed imaging, MRI, CT, and DSA, but very encouraging, like up to 88.6% adequate occlusion and 90% Raymond-Roy 1 at any time of follow-up here in the interim analysis. But again, this is not the official results. We obviously have to wait till enrollment is completed and we see the one-year follow-up DSA. Here a few examples. So this is a really nasty looking aneurysm, pretty challenging to treat, to be honest, with any type of treatment. Here very wide, like 9 millimeter on this, on an AP. But if you look on the lateral, so here it's only like 5 millimeters. So we settled with like a 9x3 seal base. Here for all these IDE trials, we have to go femoral. Most of the time we go radial, to be honest, with cases, but for all the IDE trials, they're femoral. And here you can see our setup. And now you can see the deployment, fairly similar to web deployment, I have to say. So you unsheath, and the base device takes a little bit longer time until it flowers compared to the arc, but otherwise they're very similar, very soft devices. And here's the final deployment of the device, and the runs before the attachment. You can see very good stasis and almost occlusion here of the aneurysm, and then you can see the final pictures. Here I did a diagnostic catheter on the other side as well, just because I wanted to make sure that we really are able to see the contralateral A2, which I wasn't sure if we get all of you know, during the treatment. So here obviously follow-ups are still pending. These are very, very new cases, so I don't have a follow-up on this one. Another case I recently did is a patient who had a third nerve palsy, rupture with CT negative subarachnoid, but LP positive. This really nasty looking PCOM aneurysm with multiple blebs. That brings us back to the first introduction slide. So you don't have to seal with these intrasaccular devices the whole aneurysm. And I think here, especially with third nerve palsy, there's actually a benefit to maybe just seal off the base of the aneurysm to let the nerve recover without having the device pushing against the nerve, because the third nerve is somewhere in here where you see the additional blebs. So here, the idea was really to focus on the proximal portion of the aneurysm. And based on the measurements, we settled with a 6x2 sealed base device. You can see the setup, and after the deployment, you can see the nice stasis. You can see almost like the tip of the aneurysm is not even filling anymore. So very, very nice stasis. You can see how the device is right here, covering the aneurysm, and all of this is contrast on the Dyna in 3D. And you can also see nicely here on the 14-second how the device is blocking off the aneurysm. Even that bleb, which is very proximal to the neck, is covered by the device. Last but not least, the Artisse device. It's pretty new, so we just started the IDE study here at Penn. I just did my first case recently. What's the difference here? If you look at the device, although it looks similar to web, the distal tip here is actually of the device's inside to soften it so that it doesn't push against the aneurysm dome. The aneurysm sizes you can treat aneurysms with this is between 3.4 and 6 millimeter in width and 3 to 5 millimeter in height. It includes in the IDE trial ruptured and unruptured wide neck bifurcation aneurysms. The device was a little bit redesigned to make it more to make it softer confine more to the aneurysm, basically, and make also the deployment easier. So this new version is now in the IDE trial in the US. The sizing, I have to say, pretty similar to the web. There's a sizing table you can see here where you basically first look at the width of your aneurysm. So here's an example. If you have 4.8 width, you go here, and then you kind of see, okay, it's probably getting into a range here, and based on the aneurysm height. So if you look at this 4.8 by 6, so here recommendation would be a 6.5 by 4. So it's kind of similar concept with other devices. So, but there's a specific, obviously, sizing table. Here also one example of a recent case, very irregular aneurysm, not an easy intrasaccular device case, I think, especially because of the angulation and the bleb in the neck. Here, these were the projections for the treatment angles, BP and lateral. So here, the delivery system is a 21 catheter, the rebar 18. So we brought that up, and you can see that it's not pre-shaped, so it's kind of like straightened the aneurysm a little bit, but so here definitely decided to deploy the device as much as possible inside the aneurysm. So tip to tip, unsheath the catheter, and once the device softens, get the system up more into the aneurysm dome. So here you can see the first step of unsheathing. So similar to the web, now it gets really soft, and now I'm bringing the system, pushing everything forward to get the device really up, and you can see how soft the device is and once I have it more in the dome, now I'm pulling back on the system to extend the device. And these were the final pictures. You can see nice occlusion of the aneurysm and preservation of both A2s. Here also on the dyno in the 14 seconds. And these were the final runs. Seeing also stasis at the top of the dome. So again, you don't have to cover everything at the dome. Again, you just want to get good lateral compression. So if you look at all devices, this was a nice summary graph from this video publication, and I added some information for Galaxy because that was not on there. So if you look at the different systems, so Web and Galaxy have definitely the most diverse and types of going from 17 system all the way to the 33. But I have to say 21 is also fine in the aneurysms I treat. So for contour and Artisse, that's also totally reasonable. If you look at the size range, so definitely larger aneurysms with seal are possible, very small aneurysms with web and contour. The attachment, pretty similar. And construction, the web is a single layer. All of the other devices are dual layer device. It really depends a little bit on the size of the device, how many wires and how much neck coverage you get, and markers. So my summary, obviously web, we have the longest data available that gave us all kind of the idea that intrasaccular is safe, and in the US, the only FDA-approved device currently on the market. The contour has a unique feature that you can really treat small and shallow aneurysms and also pre-treated aneurysms, including PCOM aneurysms, especially in the trial. The results are still pending from the IDE, but we have good results from Europe. The CLIT, very fast enrollment in the trial, fastest ever. Very favorable for large aneurysms, as you saw the sizes, and possible new indications, especially sidewall. That would be interesting to see that subgroup, also how that behaves compared to float aversion, for example, in the future, or ruptured. And then Artisse also just started here in the US, soft device. It really confines with the aneurysm rather than reshaping the aneurysm with the device, and will be interesting to see what we find here in the IDE study. So a lot to come. So thank you again for inviting me, and I hope that was helpful to give my personal overview about all these devices. Thank you.
Thanks, Jan-Karl. That was great. Really enjoyed that. I had a couple of questions in terms of
deliverability and detachment. Just wanted to get your thoughts on, the sealant device is quite a lot larger. Did you use any of the very large devices, and what was the deliverability of that? And then if you could make some comments on sort of sticky detachments with any other devices, or reliability of detachment, or any other thoughts on that, which has been a kind of a topic of discussion. Thanks.
Yeah, I mean, I think that's very important. I mean, I think the sticky detachments, so with Contour, I didn't feel any sticky detachments as far as I remember. Seal it the same. Artisse, my experience not much, so I can't really speak to that. I think for web, it improved recently, the sticky detachment. Deliverability, I would say it's great with Seal, also with the larger devices. To be honest, I didn't really feel that the device is pretty large when it went through the catheters. But obviously, you have to upsize then your micro catheter, so the whole system is a little bit larger. But it's yeah, I would say it's very comparable. The detachment itself, only the web and the Sealit have the detachment system currently available with like classic electrolytic, similar to a coil detachment. The Artisse and the Contour and the trials were still, with grounding, so a little bit, but still no issues with the detachment with these two devices, despite the fact it's a little bit more cumbersome because you need a needle. But
Yeah, and if you had your kind of standard wide neck bifurcation aneurysm, middle of the road size, and you have all four devices in front of you, and the reps are not badgering you, what would be your choice?
yeah, so currently it's pretty easy because I mean we just have the web available, right? Once we have FDA approval, I hope we see all the data from what is the occlusion rate, and I think that would dictate my choice. If we can see that Contour or Seal or Artisse has a higher occlusion rate than web, then obviously I would prefer that for my patients. If it's really like the standard aneurysm where everything would be the same, and then I think there are some choices in terms of if it's very shallow, I think Contour works really well. If it's small. If it's large, then I would rather use a Seal because giving the size and more material in the aneurysm, as we know that in with other devices, potentially if there's not enough material for larger aneurysms, there's a higher chance of recurrency. So I think for me, it would really dictate like the occlusion rate. So in comparison to web, it will be really interesting to see what the results will show. Hopefully we know more in a year or two.
Right. Yeah, we can't wait. One last question from me, and then I'll open it to the floor. For fellows or new attendings that are getting into the endosaccular flow diversion space, are there sort of cases that you would suggest they tackle first? Kind of what's your poster child case to be doing your first few cases? And then sort of dovetailing into that, what are the cases that you would say, hey, you probably want to do maybe 10 cases before you tackle these more difficult ones?
Yeah, I mean that's a very good question. I think the really straightforward ones are the one where it's like a straight deployment. So especially basilar tip, or I see a terminus where it goes like really straight up. There's no angulation within the aneurysm, and really also deep aneurysms where you can practice different deployment techniques, either just unsheathing the device or being a little bit low and be also able to push the device safely open. The more shallow angulation and also ruptured cases are, I think, cases I wouldn't do initially, and just get first pretty straightforward cases under the belt.
Great, thanks. Clint, any questions from the floor? No, I don't see any from the floor. The one question I always have with these intrasaccular devices is they have that like little remnant piece that kind of sits into the parent vessel. So in your practice, have you been keeping that? Do you keep them on aspirin, or do you kind of just not utilize antiplatelets for them?
Yeah, that's a very good question. So I'm not really worried about these proximal markers sitting low. For every intrasaccular device, I actually prepare them on dual antiplatelets before. because I'm not sure if I need to stent or if I have to change the plan. So I want them on this. If I do a normal web case, and I was able to deploy the device, and I don't have any restriction on the bifurcation on the branches, the side branches, I usually stop the dual antiplates right after. If I have any doubt, if it's more than 25%, obviously if it's more than 50, I stent. If it's like, if I definitely see encroachment into one of the branches, I keep them on dual antiplatelets, sometimes like a month or something, and continue aspirin. For the trial patients, I'm more cautious because it's a new device. I don't know the device. So most of the time, so we usually keep them on dual antiplatelets for like 4 weeks, and then I continue maybe baby aspirin for another 3 months. But it's usually also in the IDE studies, there's not like a specific rule what you have to do, but I'm definitely more on the cautious side. But then after that, I don't keep them on any single or dual antiplatelets, and even if the little tail is hanging in there, it's like I was very worried about that too in the beginning. We started doing intrasaccular, but I haven't seen anything. Not sure, Stephen, if you have any other thoughts, but
no, I mean that was the teaching, wasn't it? Was to have the handle or the detachment in the neck of the or in the parent vessel below the neck of the aneurysm, and initially it was kind of hard to look at, but now we want to see that if it's in the neck of the aneurysm or higher, kind of in that sort of divot, that those are the ones that tend to recur in the kind of the base of the aneurysm. So you actually want that in the parent vessel, that handle or detachment.
Thank you.
Got other questions? Nothing in the chat.
Nothing in the chat.
Well, thanks, Jan-Karl. Okay. We really appreciated having you with us today. Really appreciate your insights. You're obviously, an expert in the endosaccular space and have a lot of experience. And just, really enjoyed seeing your different techniques and especially some of the more complex cases and difficult deployments with the angulation and feeding these intrasaccular vessels, sort of curving them into the aneurysms is that takes a lot of skill, and it's not your kind of early cases deployments, as you mentioned before. Those are very difficult deployments, but you make it look easy. We appreciate your insights, and we look forward to the latest results from all these intrasaccular trials, and we'll have you back in a year once we have all the data.
Sounds good. All right, thank you again for having me.